Hi, everyone. I'm Jerome Crowley. I'm the Heart Center ECMO Director at Mass General Hospital, and I really appreciate the opportunity to talk to you about ECMO during the COVID-19 pandemic from the point of view of the anesthesiologist. I have nothing to disclose. So we're going to go over the basics of ECMO. We're going to talk briefly about ECMO and COVID-19. I imagine most people in this call are actually probably getting quite tired of talking about the COVID pandemic. So rather than spend a lot of time talking about what might have happened at a single snapshot in the pandemic, we'll talk a little bit what we learned. Then I think what is the most important part of this talk, which is the anesthetic management of ECMO patients. Many centers have grown or created new ECMO programs during the pandemic, and these patients often need care for operations and procedures outside the scope that usually is a domain of either cardiac anesthesia or the intensive care unit. And as such, the general anesthesiologist should be familiar with the different pearls that come into play in the management of these patients. So briefly, the basics of ECMO. So what is ECMO? At the end of the day, ECMO is a device to provide gas exchange outside the body. The concept is very old. Robert Hooke, of the frame for Hooke's law in Springs, came up with the idea of an extracorporeal oxygenation in the 1600s. And the first practical oxygenators, a bubble oxygenator, were developed in Europe in the late 1800s. However, significant trauma led to the blood bubbles interfacing with the blood interface, led to their not suitability for prolonged use until the early 1980s, when membrane oxygenators developed using polymer membranes, which is much less blood trauma, enabling support longer than just cardiopulmonary bypass. However, even before this happened, the first successful use of ECMO in an adult patient was reported in 1971 by Dr. Hill in Santa Barbara, California, cannulated a young man, 24-year-old, after a motor vehicle accident, traumatic aortic dissection, who developed what they called shock lung, that we'd all call acute respiratory distress syndrome. Came for VA ECMO. After 72 hours of support, was successfully decannulated and survived. In 1979, a randomized trial of 90 patients looked at ECMO in ARDS. They randomized people to partial VA ECMO, VV ECMO had not been conceptualized yet, or mechanical ventilation, and there's very poor survival. And this really kind of dampened the enthusiasm for ECMO moving forward, as the survival seemed pretty pitiful and not worth the resource utilization. But we look back on this and we see that people have been on the ventilator for a long period of time prior to going to ECMO and had lost almost 2 liters of blood a day, neither of which is compatible with a good outcome in the ICU. Dr. Bartlett, one of the fathers of ECMO in 1976, uses ECMO to save an abandoned newborn. And the use of ECMO in neonates kind of thrives here with excellent outcomes. And that really continues the trend to keep ECMO alive, but almost no use in adults. I'll put this point here that in 1990, the total number, if you see here almost in 1998, the total number of ECMO runs is probably less than many centers for 1 year now. And that was around the world. And so we see up to 2009, there's almost no use of ECMO. And what really changed this was the H1N1 pandemic, pandemic round one, so to speak, that I remember when I was a trainee. So just to review, during the challenge here, the acute respiratory distress syndrome, this concept of diffuse fluid damage, and the standard treatment is supporting the lungs until they can recover enough. And this is a very important concept because ECMO is no different in that way. It's not a treatment for anything. ECMO serves to support the lungs until they can recover, whether another intervention or time is going to come into play. And one of the consequences of this is to avoid causing more injury, which we know is possible with mechanical ventilation. This has been known since the 1700s, and Dr. John Forthiel talked about this. We know mechanical ventilation through reeds in someone's trachea said that bellows are not as ideal as a person breathing for you, because the bellows can breathe too much into your lungs. They already kind of had an idea that low tidal ions might be the way to go, which took us some time to catch up. So the strategies are well known to the audience here. We limit tidal volume, we call this lung protective ventilation. We limit inspiratory pressure. We limit the transpulmonary driving pressure, which is the difference between the plateau pressure and the PEEP. We optimize the PEEP to improve aerated lung size, to prevent cyclic strain, which is collapse and reopening of alveoli, and reduce overcirculation of blood to areas that collapse and represent a significant shunt fraction. We attempt prone positioning to improve aerated lung. This has been shown in a randomized clinical trial to improve outcomes and mortality. We try to limit the respiratory rate, recognizing that high rest rates are likely injurious. We limit spontaneous respiratory effort to reduce ventilator noncompliance and the desire of a patient to take too big a tidal volume and injure themselves. But if they all fail, someone is still hypoxic, still acidotic, still has hemodynamic instability, right ventricular failure, what do? I want to point out that ECMO is studied in two subsets here. The big one that we look at is what level of hypoxia is the time to consider ECMO. A very different question is if someone is so hypoxic they will die this instant without ECMO. That is harder to study because the survival rate in the control group there is 0. They're dying without ECMO. And so that group has never been subject to a randomized controlled trial. So we're going to focus instead on people who are not actively dying, but instead are so hypoxic or acidotic that we worry they will head that direction, and there's a survival benefit to ECMO. And so this thought in the biologic plausibility, which is always important to identify with ECMO, is to enable improved lung rest and reduce ventilator-induced lung injury. And so there's this overhanging question: does VV ECMO benefit in severe ARDS? And if there's a benefit, we'd expect this benefit to exist if we insert ECMO early, as this reduces the burden of ventilator-induced lung injury, and that late ECMO initiation likely will not have much benefit. So this is the first trial, the Caesar trial, which looked at the efficacy and economic assessment of conventional ventilatory support versus ECMO. So a randomized trial in the United Kingdom, 180 patients with severe respiratory failure, who had been intubated for less than 7 days, were referred to be randomized in this trial. They were transferred to the ECMO arm. They were transferred to an ECMO-capable center, and they had a mechanical ventilation strategy. And if they failed that, they were cannulated for VV ECMO. The control group was on conventional ventilation or high-frequency oscillatory ventilation, which is something that at the time was not known to be harmful. The primary outcome is death or disability at 6 months. And so we saw as improved survival in the intervention arm. However, this doesn't say ECMO helps survival. It says transfer into experienced center helps survival, which I think is an important point here. We know this in a lot of disease processes, that centers that are more experienced tend to do better in managing them. And it's also important to note that the ventilatory management differed between the two groups. So not really adherent to best practice for severe respiratory failure. And you said the oscillatory ventilator, which we don't use much in adults anymore, kind of throws a wrench in our plans. So it doesn't really answer our question. So flash forward to 2018 to the EOLIA trial, extracorporeal membrane oxygenation for severe acute respiratory failure. And this is a multi-center randomized trial for ARDS, which had pretty reasonable inclusion criteria, as well as exclusion criteria, ventilation duration more than 7 days, a high BMI, long-term chronic respiratory failure, shock, or inability to tolerate heparin. They also had a very good protocolized way of managing the ventilator, which kind of reflects, I think, a lot of our standard ICU practice. That said, if still refractory, the patient could cross over to the VV ECMO arm. And at 60 days, there's no difference in mortality. The trial was stopped due to futility. However, the ECMO group had a low risk of treatment failure, so death versus a composite death or crossover ECMO, lower rates of RRT. Their conclusion, though, was that no significant benefit from mortality at day 60 compared to conventional mechanical ventilation. So there's a lot of strengths here. So maybe we take from this, ECMO isn't better, and we don't see mortality benefit. But a couple flaws of the trial: it was underpowered. They had predicted a 60% mortality in the control group, which was probably too high. ARDS management had improved since the inception of the trial, and survival was slightly better than this. And a risk reduction of 20%, while ideal, is probably too optimistic. And a high cross rate of controls. And was the inclusion criteria too liberal, too conservative? It wasn't entirely clear. But there were still some signs that we were missing a true benefit of ECMO for ARDS. We had this biologic plausibility from animal models that made it seem that there should be a subset of benefit here. So first, some more advanced statistical analysis was done using Bayesian analysis. And what we find here is that Bayesian inference, which is a probability testing model to allow us for hypothesis probability adjustment based on prior evidence. A nice way to summarize this is if the evidence up until this point suggests a true outcome, then the burden of proof your study has to provide is lower than if your study kind of contradicts the burden of evidence that exists so far. And based on how much enthusiasm, which is a statistical term in Bayesian inference, to say the burden of proof before, you can say that the EOLIA suggests a benefit of ECMO. But you gotta be careful because as data becomes more robust, this can change. And again, it's very expensive, requires significant expertise, so we really still weren't sure. Until thankfully, right before the COVID pandemic, a meta-analysis was done using the patient data from both the Caesar and EOLIA trials. And they showed in patients who received ECMO had more days out alive without multi-system organ failure, a rate of death or composite outcome, and significantly lower 9-day mortality. And this seems to suggest that for patients with severe medically refractory acute respiratory distress syndrome, VV ECMO is a reasonable treatment strategy. I want to take a pause there, though, and talk a little bit about that review. One interesting fact was that once you had more than 2 organ systems injured, and the lungs are already one of them, the mortality benefit evaporates. We also saw that while 7 days was the cutoff, the majority of patients came within 3 days. They had BMIs less than 45. And so what's difficult to extrapolate here is all patients with ARDS, because often as a referring center, you are called for someone who's been on a ventilator for many days. What is the impact of high flow nasal cannula or BiPAP before intubation? This is a phenomenon called self-induced lung injury, where a patient is injuriously breathing themselves before being intubated. What is the contribution of that to outcomes in ARDS? These are unanswered questions that presented a real challenge in COVID. So COVID, however, a large influx of severe ARDS of younger patients to ICUs. And the big questions came up. Does ECMO have a role in the management of severe ARDS from COVID? What factors may play a role in survival on ECMO? ECMO is a limited resource. So who is offered ECMO? This is a table from a recent trial in the Annals of Intensive Care Medicine that looked at outcomes of multiple trials on ECMO. So we go through here and you see these are all case series, retrospective single center. We have one prospective multi-center cohort. Nothing is randomized. And the mortality rate varies hugely. The ECMO duration varies significantly. The management proning before ECMO varies significantly. And what we saw in a trend throughout the course of COVID and ECMO is that initially mortality outcomes were very poor in a very small case series, then looked very good and almost better than average, and then kind of came back down to earth again to sit around a survival rate between 40 and 50%, which is right in line with what we expect for ARDS, and continues our recommendation that for refractory ARDS, venous ECMO is likely reasonable as a management strategy. So what we often are worried about or thinking about is a situation in which you have a limited resource, you have a patient who's very sick and critically ill, and you want to help them. And is ECMO going to help them? And I will be honest with you that I'm not sure we still know the answer to that. What we have gleaned from this, and again, in retrospective and case series, is that patients with significant ARDS, significant renal failure, are likely not great candidates for venous ECMO and COVID. Patients who are older are likely not good candidates for ECMO and COVID. The reason being that the duration of support needed portends a prolonged recovery time, which will likely be poorly tolerated in patients needing hemodialysis or venous ECMO for a long period of time, or elderly patients who don't have the physiologic reserve. This is challenging because you have a lot of patients who we often get called in the middle of the night to say this person might need VV ECMO, they're not doing well on the ventilator, and they're from either an outside hospital referring facility, they're from in your own hospital, and you always want to say yes. But you have to remember that one of the biggest harms you can do in ECMO is to put a futile patient on ECMO and then just kind of string the family and the patient along. That's not fair to do to them. So mortality is varied, but the trend is towards use in younger patients with fewer comorbidities. They have long recovery times, and the use of lung transplant in this population is debated. There are centers who've reported good outcomes. There are centers who have not been aggressive with lung transplant in this patient population. And as the variants have changed, we've seen less ARDS from COVID, we may never know the answer if this is appropriate. I will say, in our current setting, with the resources we have, if you have a patient who is younger, I think it is very reasonable if early in their treatment course to offer them venous ECMO for refractory ARDS. But early in the treatment course, less than 7 days of mechanical ventilation, with some debate about what the duration of high flow nasal cannula or BiPAP before intubation means. At our hospital, if they've been at our hospital and been on settings of high flow nasal cannula or BiPAP that are not close to intubation, which we view as someone who's less likely to have self-induced lung injury because they're not working so hard to breathe, they're not so borderline they should have been intubated. We're often willing to extend that window to 10 to 14 days. For patients from other hospitals who have been on very high non-invasive ventilatory settings for days and days, I worry that is no different than being intubated in the world of respiratory failure and makes you likely not a good candidate for VBEC. So I want to take a step there, we're halfway done, and talk a little bit about the anesthetic considerations of these patients, because I think what we have learned from this is as more and more ECMO patients come into play, I think it's more beneficial that we're aware of what to do as an anesthesiologist and how these devices work, because there may be another pandemic, there may be more use of this device. As your hospital expands use of ECMO, you'll see more of these patients. So the first thing that comes up on venous ECMO is how much ECMO flow do you need? You'll hear people talk with this on ECMO, right? There are two settings, the RPMs, and then you're going to have the fraction delivered oxygen and the sweep gas flow. We'll get to this in a minute. Assuming a fraction delivered oxygen, the FDO2, is equivalent to the FiO2, like on the ventilator. That's the percentage of the gas going the ECMO circuit that is oxygen. And the sweep flow is roughly analogous to the minute ventilation. So one determinant of oxygenation is that FiO2. So we can set that at 100% easily. So how much flow do we need? Well, if we do the math, for cardiac support, it's easy. We can estimate a cardiac index of 2.4, multiply that times someone's body surface area for VA ECMO and decide this is our flow. For VV ECMO, it's a little bit more complicated. We know that 70% of blood must participate in gas exchange to adequately oxygenate the blood. The less the lungs do, the more the ECMO circuit has to do. In people with COVID ARDS or ARDS that has such severe injury, the lungs are doing minimal work. Your ECMO flow must be 70% of the cardiac output to have a saturation to 90-94%. Certainly, a sat in the mid-80s is more than compatible with life. But as far as stability for transport, stability to tolerate procedure, you may wish to have a saturation a little bit higher. And so I chose 70% to give you a sat about 92-94% based on the math. How do you estimate the cardiac output? The easiest way to do this is with echocardiography to look at your LVOT VTI. Once you're on ECMO, the PA line no longer is valid as a measure of cardiac output and is far less helpful. So one thing in anesthesia to think about is what to do with this blood flow, because what's going to change in anesthesia with the cardiac output? And how's that going to affect the ECMO, which we're going to talk about soon. Other things to think about with COVID-19 is the use of VA ECMO for myocarditis. That's been rarely reported, but certainly somewhat prevalent in experienced centers. And the fact that many centers didn't have an ECMO program and now do. So let's kind of go through this and what to do with an ECMO patient coming to the operating room. The ventilator is usually set at lung rest settings. In the event of an ECMO catastrophe or ECMO failure, be ready to adjust to real settings. This is often forgotten because you're already intubated in the operating room, and adjusting the ventilator is not for the first thing in your mind. Poor gas exchange usually limits inhaled anesthetic efficacy. So I'd recommend using a total intravenous anesthetic. Consider depth of anesthetic monitoring to ensure you're having appropriate depth of anesthesia. Venovenous ECMO presents two unique complications. One is, I'll go to the bottom here, as we talked about the cardiac output effect. Surgical stimulus can drastically increase the cardiac output. So you need to make sure you have adequate analgesia, or else you'll find yourself being unable to oxygenate the patient appropriately despite what was prior a normal oxygenation level in the ICU. Secondly, there's a phenomenon where the ECMO circuit, if the cannulas are too close together, that the blood will pass through the ECMO circuit rather than going systemic. And this reduces the ECMO circuit efficiency. And this is not uncommon to happen when you go to the operating room on ECMO because the cannulas can migrate. So it's always important if you have issues with ECMO to recheck cannula position. Veno-arterial ECMO has some other specific considerations. So limb ischemia, left ventricular distension, which is a lack of LV contractility, which leads to thrombus formation in left ventricle or the proximal aorta. And this can be exacerbated by anesthesia due to decreased contractility for anesthetics. So monitoring of aortic valve opening is important on VA ECMO. We talked about pulsatility. Someone had a valve replacement. This is critical because the mechanical valve will rapidly thrombose and become non-functional in the setting of a non-contractile heart. Very low threshold for transesophageal echocardiography intraoperatively to look at cardiac function and cannula position. And then a phenomenon which we'll address called North-South syndrome. North-South syndrome is a phenomenon unique to peripheral veno-arterial ECMO, where the blood flowing from the femoral arterial cannula, flowing retrograde, is going to run into the blood being injected from the heart, the native blood. And at some point, it's a period of mixing. If someone also has very poor lung function, such as in a COVID patient, this mixing will result in the brain and the coronary seeing hypoxic blood. This is why we're looking for the arterial line to be placed in the right upper extremity to sample blood that represents the right carotid artery. And then the treatment here is going to be kind of some advanced management beyond the scope of this talk, but the biggest one is going to be adjusting that cardiac output. And again, if the surgical stimulus has more cardiac output, maybe you need to adjust the depth of your anesthetic. And this illustrates this phenomenon of North-South syndrome, where we see here this mixing point, and you see the hypoxic blood in the aortic arch. And the treatment for this can vary. The biggest one is optimizing lung function, adding additional ECMO support to the venous side so that we're able to pre-oxygenate the blood, or simply adjust our anesthetic plane so the increase in the cardiac output has been treated. These patients are anticoagulated. The drug of choice is of debate. Heparin is commonly used due to experience, but bivalirudin is an alternative that has been addressed in several recent studies. Goal is if ECMO is running high enough flow rates, greater than 2 to 3 liters per minute, you can likely run the circuit without anticoagulation for a period of time, recognizing that, it's all a risk benefit. Remember that active resuscitation, FFP and platelets and cryoprecipitate can use a prothrombotic state. ECMO patients are often thrombocytopenic due to consumption by the circuit or rarely development of heparin-induced thrombocytopenia. DIC is very common on the ECMO circuit, and one thing to check is to make sure that the person doesn't have thrombosis or sepsis, two very common complications in ECMO, which will precipitate DIC. So if you're called as the anesthesiologist in the middle of the night to take care of this patient on ECMO, you should recognize that surgery on ECMO should likely be emergent. We shouldn't do elective procedures, or only possible with ECMO, which may reflect an injury to the lung or thoracic surgery requiring one lung ventilation that will not be tolerated with regular lung isolation techniques and require ECMO support. We want to minimize vascular punctures, as hematoma formation is common due to heparin. And remember, lipophilic drugs, particularly fentanyl, are bound to the circuit, will often need higher doses of efficacy. Commonly, we prefer hydromorphone or morphine in these patients to reduce this complication. Central lines will often needed on ECMO patients, not without risk. The biggest one is air entrainment. And remember, the closer the tip of your central line is to the drainage cannula, the higher the risk. So if on X-ray, your central catheter is very close to the drainage cannula, be very, very, very vigilant to avoid air entrainment, as this can cause an acute circuit failure. We go through here and happy to talk about the discussion of how to place central lines on ECMO. Remember, arterial lines similarly have risk of hematoma formation, and we recommend compressible sites in the event of bleeding complications. So now let's run through a couple of complications in ECMO that hopefully you'll never encounter, but may will, particularly as you're in the elevator transporting this patient. So the first is cardiac arrest. If someone is VA ECMO dependent and they arrest, they will need to get back on ECMO. There is no way they're going to survive without ECMO. That's the reason they're on ECMO. So you need to do CPR, ACLS, ventilate the lungs, then prioritize getting back on veno-arterial ECMO. And if that is not going to be able to do it, we'll recognize your arrest resuscitation likely to be futile, to keep that in mind. Veno-venous ECMO is a little bit different in that VV ECMO does not directly provide cardiac support. However, a patient who's truly dependent on veno-venous ECMO will not be resuscitatable just from mechanical ventilation. And so while you can try to optimize a ventilator, it's unlikely you'll succeed, and it's very important to maintain VV ECMO flow. So what I often recommend doing, in addition to ACLS and ventilating the lungs, is to go ahead and turn down the ECMO flows to minimum and slowly come back up with CPR until we call capture the flows to improve oxygenation. And always ask yourself, is this patient a VA ECMO candidate? As converting to VV from VA ECMO can be relatively quick and can often salvage a patient who's a good candidate. And it's something to discuss anytime a veno-venous ECMO patient is going to the operating room, talk about are they a VA candidate in the event of catastrophe. So you're in the operating room. I've listed here some factors that we think about for pre-ECMO initiation. Echocardiographic assessment, VVVA, look at right ventricular or left ventricular function. Look for intracardiac shunts. Someone who has a significant intracardiac shunt will be difficult to separate from ECMO, as any right to left shunt that develops will cause refractory hypoxia that, while well treated with ECMO, is difficult to fix. Those are aortic dissections, pericardial effusions, air regurgitation. During cannulation, you want to monitor cardiac function. To guide cannulation, you want to look at the wire visualization. It's important to keep these wires in position while the proceduralist is performing the ECMO cannulation to make sure the wire has not migrated, causing more ECMO complications, which hopefully none of you have seen, but I've certainly reported. The arterial cannulation, we're looking for the descending aorta. We're going to watch visually for aortic dissection. The venous cannulation is a little bit more complicated. For femoral cannulation, we want to see the wire in the IVC, ideally crossed into the SVC to make sure it doesn't enter the right ventricle, which can allow a cannula to migrate into the right ventricle and perforate the RV, which can be catastrophic. I wrote some instructions here on what to do with a transesophageal echo probe, which I'm happy to talk more about in the discussion. The jugular cannulation is similar. You're going to see the wire come from the SVC to ensure venous placement. For a dual lumen cannula, we're going to watch the SVC go into the IVC. We're going to ensure that the wire does not enter the right ventricle and instead goes into the IVC without coiling in the heart. Once you're on ECMO, echocardiography is paramount to look for aortic dissection, developing effusions, any new vascular pathology, left ventricular dilation, or cannula migration. And again, I cannot emphasize this enough that in a patient sick on ECMO, a transesophageal echo can be life-saving in the operating room to rapidly diagnose a problem. PA catheters can be beneficial on veno-arterial ECMO, is that increasing mean PA pressures may reflect worsening LV distension and trigger either an echo or a decision-making what to do. On veno-venous ECMO, they're less beneficial. While the PA pressure is still valid, the mixed venous oxygen saturation and any thermodilution cardiac output are not valid to the VV ECMO circuit. And so the ability to monitor cardiac performance is reduced. And then Low flows, despite adequate central venous pressure, may represent cannula malposition. One of the challenges becomes as we move patients around, they get light, they start breathing, they bear down in the abdomen. They may be cutting out flows or reducing flow in the ECMO circuit. It's important to both verify cannula malposition, which may happen as we transport these patients. If you're called to assist with weaning of ECMO, which again is another kind of talk in itself, just to make sure you have the right preparations in place. And again, things to look for in the left ventricle, right ventricle, mitral valve. And one of the things that's worth noting when you're called to the bedside to evaluate somebody in shock, which is becoming more and more of the role of the anesthesiologist is patients, that severe MR can mask LV function, and it can appear that the left ventricle is functioning normally despite having significant mitral regurgitation, which actually is an underlying degree of LV dysfunction. So you're in the operating room with the patient, and the perfusionist, the ECMO specialist, tells you, I'm having trouble flowing on ECMO. The first thing to look at is make sure lines aren't kinked with patient positioning. As we get creative in patient position in the operating room, moving on beds, raising bed rails, we often kink the lines by accident. A phenomenon called fluctuations or chatter, the line seems to cut flow in and out completely, usually is because the vein collapses intermittently around the line tip. This can be temporized with volume, but you should then make sure to ensure appropriate cannula position to make sure that the vein does not move to the wrong vein, or you don't have something like abdominal compartment syndrome or thin abdomen that is compressing the cannula, reducing your venous drainage. High access pressures, so trying to flow the circuit higher than the circuit is designed for, will lead to hemolysis, renal injury. And then always look for clots in the circuit if it seems like you're not able to drain adequately despite adequate cannula position. Bleeding around cannulation sites is very common. So the venous line, the most common way to treat this is to hold manual pressure. We can suture the skin. We can inject it with hemostatic agents and pack of hemostatic agents. We can hold the heparin temporarily. In the event of a catastrophic bleed, if in the event of surgical intervention, you can give protamine, but that will likely worsen clot propagation in the membrane, and so we prefer to avoid it. The arterial line, unfortunately, is not as amenable to these techniques, though manual pressure is still first line to prevent bleeding around the cannulation site. If there's significant concern of vascular injury, then vascular surgery should be consulted. And unfortunately, this can happen with cannula malposition when you move the patient around. Small amounts of bleeding, which are not uncommon from widening the skin hole, are very reasonable to treat with manual pressure or suture. Significant vascular injury requires surgical intervention. Pump failure is a very rare complication and will alarm, and this necessitates an emergent circuit change. Sudden loss of AC power or battery failure could often be rectified with a backup pump or with the hand crank event. And this is something that should be drilled at your institution and anyone taking care of ECMO patients. A suction event, which is the complete loss of flow, is treated somewhat paradoxically, which is to reduce RPM so flow recovers, add volume, and slowly ramp up into what we call capture, which is regain flow at a good level, and then recheck cannula position. The drainage cannula decannulation and accidental, it can be catastrophic. You'll have perfuse bleeding from the venous site. Peripheral ECMO, you're going to hold pressure. Central ECMO is likely a terminal event unless you have a cardiac surgeon immediately in the room. You will immediately entrain air into the circuit. Circuit will acutely fail. You need to immediately start resuscitating the patient, ventilation, CPR, get blood in the room, a new ECMO circuit, and preparations to place a new ECMO cannula if the patient is salvageable. Return decannulation is a similar catastrophe with the added drawback that it will then attempt to pump all the blood out of the patient into the room, which will very quickly exsanguinate the patient. So the solution here is to quickly clamp the circuit, which may seem counterintuitive in the moment someone is coding, they're on ECMO, they're not doing well, why would I clamp the circuit? Then have acute disconnection with the patient, this is critical to prevent exsanguination. If you suddenly lost an arterial cannula, you need a lot of pressure, it's a large hole. The central ECMO, there's a large hole in the aorta. You again will need rapid surgical consultation. You need to get a lot of volume in the patient and preparations to get back on ECMO, a new circuit, and then manage the patient. Air entrainment, large air will cause pump failure. So you need to clamp the circuit and then replace it quickly. Air entrainment of the patient, if it's venous, you can attempt aspiration with the head down position or let it attempt to pass through the lungs. Remember, you're already oxygenated appropriately, so the lung failure is not as acute of an issue. Arterial may require neurology consultation for hyperbaric oxygen if the air has been injected into the neurologic circulation. A hole in the circuit, which can happen in the elevator, just occlude it with your finger. A tegaderm is often enough, just enough to occlude rapid bleeding. If it's on the outflow limb, back to the patient, will be under pressure, it will not entrain air. A hole on the inflow limb will entrain air, causing a rapid circuit failure. So the trick is to clamp the circuit and then replace the circuit while leaving the patient cannulated. And what will fall to you as the anesthesiologist is to manage this rapidly unstable patient while the circuit is clamped. Finally, we're going to talk a little bit about left ventricular distension, which is a development, we say elastic contractility. And these are some of the options here to treat that. And finally, we talked about worsening oxygenation already on VV ECMO. So I want to thank everyone for their time. I look forward to an enlightened discussion soon. Thank you.